Hey everyone, and welcome. Today, we're tackling one of the biggest topics you'll see on the NCLEX and, in your actual nursing career, chest pain. Being able to tell the difference between angina and a myocardial infarction, well, it's not just about passing a test, it's about saving a life. So let's get into it.
So imagine this, your patient has chest pain. Is it angina or is it a full-blown MI? How fast you can figure this out and what you do next is absolutely everything. In this explainer, we're going to break it all down. The key differences, the diagnostics you need to know, the priority nursing actions you have to take, and of course, the big takeaways that'll help you crush this on your exam.
All right, first up, let's talk about angina pectoris. I want you to think of this as the heart's warning light blinking. It's chest pain, yeah, but it's caused by ischemia, which is just a fancy way of saying there's a temporary drop in blood flow. Now, the most important word on this slide, reversible. Say it with me, reversible. With angina, the heart muscle isn't permanently damaged, at least not yet. Now, just to make it interesting, not all angina is created equal. You've got stable angina, that's the predictable kind. It shows up with exercise and it goes away with rest or a little nitroglycerin. Simple enough. Variant angina is a bit weird. It's from a coronary artery spasm. But the one you really have to have on your radar is unstable angina. This is a huge, flashing red light that a heart attack could be right around the corner. And this is the big one. A myocardial infarction, or an MI, a heart attack, this is what happens when that ischemia, that lack of blood flow, doesn't get fixed. The blood flow gets cut off completely, and that leads to necrosis, tissue death. And here's the key difference from angina. An infarction means permanent, irreversible damage. You don't get that heart muscle back. Okay, you're going to want to screenshot this slide because this is basically your NCLEX cheat sheet. The most critical piece of this whole puzzle is right here in the relief and duration columns. Look, if the pain vanishes with some rest or a nitro tablet in less than 15 minutes, you're thinking angina. But if that pain is hanging around for more than 30 minutes and only strong opioids are touching it, you are deep in MI territory. And don't forget those other symptoms, nausea, sweating, feeling like you can't breathe. Those are practically screaming MI. All right, so your gut is telling you it's an MI. The first thing you're going to look at is the EKG. The EKG is telling you a story in real time about what the heart's electrical system is doing. So what exactly are you looking for in that story? What are the clues? And here's the decoder ring for that story. If you see ST depression, that tells you the heart muscle is ischemic. It's starving for oxygen. You'd see this in angina or an NSTEMI. But if you see ST elevation, that's a whole different level. That means injury. The muscle is actively being damaged right now. That's a STEMI, and it is a code red medical emergency. And that abnormal Q wave, that's evidence of necrosis, of cell death, proof that a heart attack has happened, either right now or in the past. So let's switch over to labs, which confirms what the EKG is telling us. See, when heart muscle dies, it bursts open and releases enzymes into the blood. Myoglobin pops up first, but lots of things can make it rise, so it's not super specific. CKMB is better. But the absolute gold standard, the one the NCLEX loves to ask about, is troponin. It is super specific to the heart muscle and it stays high for days, which gives us a really clear picture of the damage. Here's the bottom line. Any positive troponin means there has been damage to the heart. Period. So let's put it together. The EKG shows ST elevation. The troponins come back positive. It's confirmed you've got a STEMI on your hands. There's a saying you need to burn into your brain. Time is muscle. Every second that goes by, more heart muscle is dying. So what are your immediate #1 priorities right now? Okay, let's talk about MONA. Everyone memorizes this mnemonic, right? But here's the real-world NCLEX level critical thinking part. You don't just blindly give it in that order. You assess your patient. Is their oxygen saturation low? Okay, then you give oxygen. Are they clutching their chest in pain and their BP is stable? That's when you give nitroglycerin. Aspirin, a chewable one, is to stop more clots from forming. And morphine? That's for pain that the nitro didn't fix, and it has the bonus of calming the patient down and easing the heart's workload. So yeah, remember MONA, but remember that your assessment drives the bus. Patient teaching around nitroglycerin is a massive safety topic on the NCLEX, so listen up. The single most important thing to teach your patient is this. If that first tablet under the tongue doesn't get rid of the pain in 5 minutes, they need to call 911. No exceptions. Sure, they can take up to 2 more doses while they wait for the ambulance, but they can't wait to call for help. Teaching them that one thing could literally save their life. All right, so beyond the chaos of the ER, we start thinking about how to save as much heart muscle as possible. That's where meds like metoprolol, a beta blocker, come in. We usually start them within 24 hours. And why do we do that?
Well, they slow the heart down, lower the blood pressure. Basically, they tell the heart to just take a chill pill. This lowers the heart's demand for oxygen, which can actually limit how much damage is done, and believe it or not, helps people live longer. For a STEMI, the name of the game is opening up that blocked artery fast. One way to do that is with thrombolytics. We call them clot busters, like Eltaplace. But, and this is a huge but, this quote highlights a critical safety check. You have to screen for contraindications. Can you imagine giving a powerful blood thinner to someone who just had a bleeding stroke or major surgery? It would be catastrophic. You absolutely have to assess first, always.
So what's the worst case scenario if the heart attack is really, really big? The heart muscle can get so damaged that it just can't pump effectively anymore. That's cardiogenic shock. It is a terrifying, life-threatening complication where the pump has failed, blood pressure plummets, and organs start to shut down. This is exactly why every single second counts when treating an MI.
So, the emergency is over, but our job is far from done. Long-term survival after a heart attack is hugely dependent on patients taking their meds. As you can see here, they'll almost always go home on a few key players: an antiplatelet like aspirin to keep clots from forming, that beta blocker to keep the heart's workload down, and an ACE inhibitor, which helps prevent the heart from changing shape and failing down the road.
And all of that leads us right here, to discharge teaching. This is where we empower the patient to stop this from ever happening again. This isn't just handing them a pamphlet, it's teaching them a whole new way to live. We're talking about cardiac rehab, a heart-healthy diet, and making sure they know their risk factors inside and out. And smoking cessation, that's not a suggestion. It is non-negotiable for survival.
So, as we wrap this up, I want to leave you with a question to chew on. Out of everything we teach our patients, the diet, the exercise, all the medications, quitting smoking, which single piece of education do you think makes the biggest difference in preventing another heart attack? The answer really gets to the heart of what long-term nursing care is all about. Thanks for tuning in.